Welcome everyone to our Health System Performance Research Network and RISE Collaborator monthly webinar. Welcome to today, February 28th. And today we're going to be talking about population health management and integrating approaches, a little bit of a sense-making undertaking. I would just like to have everybody please begin by entering into the chat and letting us know who you are joining us today for this webinar. I look forward to it. Let's see, who do we have? Hopefully everybody can chat. John McKenna, first off from home country, Rob. Mississauga Health Team. Judy Porteous, Kathy Whiteside. Welcome, Kathy. And here we go, Matt Meyer from out in London Way. Jazz Kahar from SE Health. Hello, everyone from Ottawa West Four Rivers. Toronto Public Health is here today. Grand River OHT, Great River OHT, Great River, Closing the Gap. They are coming in fast and furious. Welcome, Megan Cunningham, please continue to type in the chat and let us know who's here. It's the best way we can start to get a sense of the audience. We have a good number of audience members with us today. We had about 370 signing up, and that will mean that we'll have a good audience for this event today. I really need to begin acknowledging the land on which the University of Toronto operates. I'm speaking to you today from the university. We have a great view here at the university out my window. For thousands of years, though, it has been the traditional land of the Huron-Wendat, the Seneca and the Mississaugas of the Credit. And today, this meeting place is still home to many Indigenous peoples from across Turtle Island. And I particularly am grateful to have the opportunity to work on this land and to share in this work with you. Many of you are coming from lands all across the province of Ontario and further abroad, some of you. I welcome you to acknowledge the land that you are speaking from and joining us from today. And hopefully you will be engaging in our chat as we go through the event today. We have a lot of, I think, really interesting conversation. And I think today's conversation shouldn't be easy. It should be challenging. And I welcome you to challenge each other and also to challenge us in this event. Okay, so we like to start off this, and I see some names that I know for sure are joining us from the first time. So I'm just going to ask if everybody could please respond into this poll about whether you're joining us for the first time or whether this is your event. Have you joined us previously? Yes, that's you've joined us previously. And if it's your first time, then let us know. We have, most people can get into this pretty quickly. Really pleased to see people joining us today. And thank you for continuing to type into the chat as you join to let us know who you are and where you're joining us from. Georgian Bay, Ethel from Scarborough, Michelle from Ottawa Health Team, Equipe Santé Ottawa. Okay, we're going to share out the results again. And I thought so when I looked at a little bit of the list coming across that we actually have over a third of people joining us for the first time today. And I think that might speak a little bit to some of the content that we're talking about. We're putting a little bit of, we're not just putting out indicators, we're actually really talking a little bit about sense making. And I'm sure that our esteemed speakers have also attracted additional audience to join us today. So thank you very much for coming. And I really hope that we will be able to really take you through an interesting journey today. And just before we start there, I just want to let everybody know that we have two reports. We've had webinars recently that talked about these. The first is findings from the Organizing for Ontario Health Team survey. This is cohorts 1, 2, and 3. We're also showing some changes over time in the leadership capabilities and the organizational capabilities of Ontario Health Teams as you begin to launch. It's actually some very useful and interesting results. And then also the results of our developmental evaluation. In November, we had our team talking about those results, and those are now available on our website. So I welcome you all to go and check those out. But today, we are really coming back to the discussion of population health management and specifically around integrating approaches to population health management. And Dr. Rob Reed, who's Chief Scientist at the Institute for Better Health, Trillium Health Partners, and a collaborative mind in that role, He's also the RISE co-lead, and he's really going to start us off on this conversation of integrating approaches. I'm going to give you a little bit of information about diabetes and people with diabetes, and then Dr. Lala Rashidian is going to join us to talk about some of the performance results and opportunities for improvement in diabetes management itself. And then finally, we are very, very privileged that Mike Hindmarsh, who's the coach lead for the RISE Population Health Management coaching team, who's been doing coaching around creating and implementing models of diabetes management for many years, decades in fact, to talk us through how does that look at the ground. So how do you operate things on the ground? So here's the arc today. First off, this general approach to advancing population health, then some data, because we are the Health System Performance Network. We're bringing data to the table to support population health management, the example of diabetes in Ontario, and then this really, on the ground approaches to improve population health and population health management. So really look forward to engaging with you throughout the entire event today. Please be active in the chat and look forward to engaging. So without further ado, Rob, I'm going to turn it over to you, and maybe you can lead us through some of this.
Sure, and thank you so much, Walter. My name is Rob Reed. As Walter mentioned, I co-lead RISE, which is one of the OHT support partners across the province, and we know many of you providing coaching supports and many other supports to Ontario Health teams. And I just wanted to start off thanking HSPN for inviting RISE, Mike and me, to collaborate on the webinar today. And my role is really short at the beginning, and as Walter said, it's really to set the context. And so I just have a few slides for you. I'm going to review some of the core concepts around OHT transformation and what population health management needs. Many of you have heard this before, and we'll use similar slides that we've used in the past. So some of you is going to be a review for, but some of you it's new concepts, new things. So we're just wanting to set the stage and level set at the beginning for everybody. As everybody's heard in the last few months, is that Ontario Health is planning to introduce a whole variety of clinical pathways over the next while. And we're going to spend some time talking about how clinical pathways and how they fit into a population health management approach. So that's the goal today, but we're going to start at the beginning and just talk about OHTs and their intent to their purpose to begin with. And this is just an overarching slide. And just to recall that at the end game, the idea is that at the end state that OHTs are intended to be held financially and clinically accountable for an attributed population, for a whole population of patients that they serve. We won't go through an attributed population definition, but it's really around what prior patterns of care looked like. And OHTs are responsible for, at their core, responsible for managing the health in those attributed populations. Some of them are relatively small and some of them are very large, and then integrating care. So they're actually responsible for managing population health and integrating care across the sector. And just the recent ministry announcement anchored in those concepts again just a few months ago. OHTs will continue to integrate care and use equity-based population health management approaches to deliver better health outcomes and provide better experiences for patients. So this is where our end goal is. And there's many parts to building the OHT capabilities, and you've been to many of our learning events before, and we talk a variety of those building blocks. And many of them, many people will say that population health data, management requires data, and you're absolutely right. It requires data to be able to do that. And Walter is going to talk about the data needs, and so will Mike, around how you make that into action. And the second point that we often hear is we've got very many pressing concerns that OHTs are required to deliver on a lot of promises over the next while. Digital initiatives, They report on measures for CQIPs. And now the introduction of clinical or care pathways for specific conditions are all on the expectations for OHTs for the next few years. But what we're going to talk a little bit about is how you can integrate these requirements into your population health management approaches, because indeed these are the building blocks, or some of the building blocks for population health management. Okay. Next slide. Remember that OHTs at the end of the day are really local, integrated, and accountable care systems. And so just a definition for everybody, those new to the OHT world, OHTs are often defined as primary care providers, specialists, hospitals, home care providers, and other healthcare providers that come together and agree to be held accountable for coordinated, quality, equitable, and value-based care for a population that they serve. And their real job is to build mechanisms to proactively, and you'll hear that over and over again, to coordinate and provide timely, efficient, and person-centered care. And as we talk through patients with particular diseases, we've got to remember about person-centered care as well as disease-specific care. And together they're held accountable for the quadruple aims for their attributed population. Population health experiences of both the workforce as well as patients and families, and around efficiencies, all with an equity lens. So that's where we're heading. That's a definition just to anchor everybody in the core concepts. Next slide here. And then as you recall, RISE and the HVSPN and many of the other Ontario Health Team support partners are really helping OHT learns the steps in population health management. And this is the 5-step model that we've introduced in Ontario and that we're all using it's a very generic model that you can apply to different populations, but it's a general approach to take. Just to briefly start, the first step is really around identifying who the population is. Who is it that we serve in there? Both the people who come in the door and we know well as the people who might not, and we actually don't know, but we're actually accountable for them in our attributed population. And then it's really understanding the needs of those patients and populations using data to understand the attributed population. And we've had many webinars about understanding about the population you serve. The second step is really around segmentation then. It's really to try to divide people into different categories based on needs, risks, and barriers to care, so that we can develop care models that are particular for the different subpopulations that we serve, often called priority populations, and so we can actually deliver on the promise to those subpopulations. So it's segmentation based on needs, risks, and barriers. And Walter and team, as well as the RISE team, have shown many different methods of segmentation, and we're going to talk a little bit more about that today. Once we've segmented populations, then it's all about designing the mix. It's around bringing evidence-based care into the mix and co-designing person-based pathways that are tailored to those particular segments and adapting them to be equitable. Then next, it's really around implementing these co-designed care pathways. We've spent a lot of time talking about co-design at the RISE and HSPN events, and we can certainly help people around the mechanics around co-design. Implementation is really around reaching the entire population so that we actually reach all the attributed population, not just the ones who come in the door, and then gradually learn by monitoring, evaluating, and changing. So that's the population health approach, the population health management that we've been applying. So let's dig in a little bit more. This is just a schematic that we currently use a lot, and you've seen that a bit. We leverage the Kaiser risk pyramid. So this is the Kaiser risk pyramid to really think about attributed populations and subpopulations, their risks, needs, and barriers, and connect them to the care model design. This picture represents an overall representation of a general population segmented into four different groups: healthy patients, rising risk, increasing complexity, and high users. And as you move up this pyramid, the size, luckily the size of the levels shrinks. But as you move up the pyramid, the health risks, the equity barriers, and the medical complexity increases. And that means that you also have increasing needs for clinical, behavioral, and social support systems. So as we think about populations, we have to think about all of these people and all of their different needs as we move up the risk pyramid. Each of the case studies that we present over and over again follow this approach for segmentation, and this is a general framework that you can use for population health management. So let's move on a little bit beyond segmentation to really around care model design, which is the next pathways. Is really then it's all about co-designing care models, bringing the best evidence to bear. And actually designing care models for particular segments of populations that we serve. And today we're going to be talking about persons with diabetes, those that have relatively that are relatively stable, as well as those that have really substantial medical complexity because of a variety of additional medical conditions and social issues. And within the care models, we have embedded care pathways. And I just wanted to anchor on this term a bit because we're going to hear this over and over again about care pathways. Care pathways are an absolutely essential part of care models, okay? They are really the steps taken to deliver a care process that includes social care as well, along the entire patient journey for the duration of their condition. And with chronic illness, it's around they have no end to their condition. And remember that the care pathways are always girded by clinical practice guidelines that we agree to, and about clinical standards that we'll see from places like health standards, for instance, from Ontario Health. Are embedded within clinical guidelines or within care pathways. Sometimes you'll hear the term care pathway also synonymous with clinical pathway, and just to know that we're referring to the same thing here. And then so care pathways are really the who does what, when, where, how of delivering care across to particular populations of patients within the care model. And then care models are larger than that. Care models are really systems of care that are often embedded with multiple care pathways and processes inside. There are very often very person-centered, include other components of care pathway, of components to enable care pathways. So for instance, the provision of decision support tools for physician offices, the deliver of self-management support resources for patients directly. And they often now start encompassing whole person care. So for instance, making sure that patients with diabetes or persons with diabetes also get their chronic care needs met, such as breast cancer screening and colorectal cancer screening. And so care pathways fit within care models, and they're based on general clinical practice guidelines and quality standards, okay? They fit, as you can see in this diagram, they fit in our population health management cycle, really in this co-design of care model phase. Okay. Let's stop there. I think Walter will go to the next slide. Yeah. So I think I'm going to hold it there, Walter. And those are the brief concepts. I think we've reviewed most of them before. Just wanted to catch everybody up to speed.
I think, Rob, that we could review that slide every week for the next year and continue to unpack what it means and how we use it. So I really, really want to thank you and the team for developing that understanding of evidence-based practice, care pathways, care models, and how it's really attributed to the entire approach of population health management. I just want to get a sense, people, right now, of your appreciation, your confidence with implementing population health management models, inclusive of these care pathways and care models, and just let us know where you would put yourself at a level of confidence, from not confident at all to being somewhat, or you may have to scroll down a little bit to get the very confident in terms of your capabilities and what you think you might be able to do at this point in time. So we have about 230 people online now, so we're looking forward to having most of you respond. And I would suggest that even if you're not with an OHT, I know a number of people on the call today are from OH or other organizations that would also be needing to implement various models of care and support that work, in fact. So answer us from that perspective, if you will. Come on in. And we're about halfway there, but I see that the number of people responding is slowing, and that's all. Now it just ticked up again. So just leave time for just a few more people to come in and get a sense of that level of confidence. Okay, and I think I go with the 3-second rule. 3 seconds without a pop of a popcorn means we come out to share the results back with everybody, and you might have to scroll down a little bit to see them all, but we actually see that it's a middling, actually. It's a very unusually normal shaped distribution with the peak and the mean at the middle of being somewhat confident, but then also people down from the not confident at all, with a few people also being up and very confident. So it's actually quite interesting that we have this spread right out to the ends of the spectrum, which helps to flavor. And Mike, when you're talking, will help maybe to flavor some of your thoughts and we'll really be interested today now. So think about that, is around, what kinds of questions do you have? Where can we provide a little bit more clarity? And I think that kind of comes back to that first image. And I'm going to kind of go back to that one slide that Rob had put up, this idea of evidence-based practice guidelines, care pathways, and care models fitting together. And now take that down and just Rob, we'll see what kinds of interactions we get with the audience here. And you might, so that's interesting. Earlier, there was a question around equity, and I see there's a few more questions coming up related to this that we'll bring up, but there was a question around equity and how do you see equity? So Rob, you mentioned equity when you talked about the quadruple aim, but maybe even in this area of pathways, models, and health management, how do you see equity fitting in? We're going to show some data later, but in terms of the approach and the thinking around equity.
Yeah, that's a really good, an important component, Walter, and it fits in so many aspects of population health management, in every aspect. For instance, making sure at the beginning we're identifying and segmenting patients, using equity perspectives as well, and what their real needs are from different components of the population. So data is really important around actually how we bring equity to life, so we understand. And care models, often we think of as a one-size-fits-all approach. And clearly what we realize is that populations, particularly equity-deserving populations, need additional or different approaches, so that we have to tailor approaches, particularly for equity-deserving groups, and really think how to do that based on the components of the data that we've actually done. So while there is some standardization that is likely required, we really have to make sure that we're tailoring to the local population and the equity-deserving groups within those populations. Across Ontario, we have very different populations of the patients we serve. And so there has to be some tailoring of the approaches across OHTs to meeting those different populations. So I'm going to leave it at that, Walter. We could talk on this topic for probably 2 hours, and we should. So let's come back to that, particularly at sometime in the future.
Yeah, so, and we may come back because there are a couple other equity related content specifically about that. Sarah Milne put in some information from the Ministry of Health on the Health Equity Impact Assessment notion, so people can follow that link as well. And this is, I like this question. I'm going to actually load this question into two questions into one, and bring an equity lens in, is around the standardizing of these clinical pathways. And then the question comes, how do you envision care pathways address the needs with people with complex health conditions? And in that, I'm going to say people with complexity, and I would add equity and social dimensions of complexity into those people. But they have the example of multiple comorbid conditions, which is a pet area of mine to study. If there's a focus on specific disease conditions. So if there's a pathway focused on a specific disease condition, we could pick, diabetic limb, or we could pick CHF. How does it encompass or consider all the other conditions that people have, or how does that play a role? And if it's a standard pathway for only one type of patient, how do we address the fact that people have different needs, maybe based on transportation, food access, other types of social determinants?
Really good question, Walter. And I think, the view is that there is likely some standardization, particularly around the clinical care that we deliver, that is needed across the province. But there's clearly differences that also need to occur in those care in the care pathways. For instance, some of the resource constraints of many of our OHTs are different than other OHTs in terms of who does what, when, where, have to be somewhat rejigged in different places. So clearly tailoring is needed. And then I really do embrace the topic of really making sure that we bring social care into the construct. So making sure that our pathways are inclusive of what of social care needs across the populations is quite important. And then finally, I think this is what I was trying to refer to as well, is that care pathways are often very disease specific. And we really ought to be thinking as we advance forward as to make them as person-centric as possible. So rather than looking at particular conditions, for instance, in very complex patients, it may make more sense to actually have a care pathways around a common end state, such as frailty. So absolutely, this is important. Don't forget about preventive care. Don't forget about acute care needs, as well as the chronic care needs that we're really focusing around many of these conditions.
Yeah, thanks for taking on that question, because I think that is a question we'll continue to wrestle with, and it's long been, I think, a challenge, because people do have chronic needs, and then they also have acute needs that crop up, and sometimes not for the same set of conditions, and we just need to build a resilient system to be able to support people where they're at a given point in time. There are some excellent chat lines coming in, and it's interesting. Earlier on, I saw a comment from Christine Olson about just the question we asked, which was around how confident are you to implement? That it being a bit of a loaded question, and it comes up in a few other threads, is that they're developing knowledge, actually, and I think, Rob, you've done a great job of helping to share that information, and through multiple hosts talking about how these things fit together from a knowledge perspective. But at the front lines on the ground, and someone else from Northern Ontario, it was Samantha Gupta talking about where they're in a rural area, there's so many complex issues, everything's a 911, and actually getting people to focus and stop what they're doing to create a little bit of space and time to implement a new approach to care. And I think a real challenge is around, you can't just layer things on and on and on. It's to figure out what you're going to stop in order to create some space. I don't know, Rob, if you have a comment. I know Mike will address a little bit of this a little bit later in the event. And we are super keen to hear from OHTs that are implementing pathways to come and share your knowledge. So reach out to us either through the community of practice workshops or through these webinar events. We are so keen on examples. So if you're doing something to land some pathways, we want to know about how you're doing that.
Yeah, Walter, I couldn't agree with more. I mean, my job today was really just to set the stage for everybody for the discussion, just around like the intents of what we're trying to do here. But really, the trick is in how you actually do that and how you embed this into the work that you're currently doing, and keeping along around a North Star in this direction. So I think I should stop now, Walter, and we should get on to the more meaty parts of the discussion.
Yeah, thanks a lot, Rob. And I'm going to endeavor, have a look at the chat, and I'll endeavor to continue to pop into that chat as well, because there are some very, very thoughtful questions, not all of which we'll get to right now, but come back to do as many of them as we possibly can, because they're such good questions and comments. And there was one around physician engagement, and every physician is attached to an OHT, but they're not necessarily all engaged. We're definitely looking forward to coming back with more knowledge and another webinar in the upcoming months that will relate to physician involvement and engagement in OHT work. So in all this work, as you can see, there's a whole population over ages, episodes of care, chronic, between sexes, genders, and types of conditions. And how can we simplify or provide a little bit of a roadmap? And that's our goal here today, is to think about a little bit of a roadmap. And you might need to start with data on the entire population and having advanced analytics to identify clusters, but you won't have all of that data. We have some data for Ontario, and we're really trying both to provide population data and then data in specific populations and indicators that we're sharing with all of the OHTs. We've done it for mental health, for frail older adults, for end of life. And last week or the week before, you received information from us on people with diabetes. We're going to continue to do this kind of work when we have indicators of quality to share out more and more, to eventually be able to, that you can look across the many different segments of your population. We're going to go through some of that data today. But at the high level, we have this overall population, and we had done this work previously, attributing out your entire population into these very complex individuals, people with rising risk, people with moderate chronic conditions, and then relatively otherwise healthy patients who might have a minor encounter with the acute hospital, or just having acute issues without an acute hospitalization, and managing those in the mostly healthy people. And one of the things that we are emphasizing today is this notion that people are not static over time. So this is a diagram that we have that shows people according to the CIHI Pop Health Grouper. Many of you have seen the data from the ministry that tells you which proportion of your population are in these different groups at one point in time. So this is some data we did previously, showing some of the transitions of people between those different groupings from one year to the next. And you can see that there's a lot of fluidity, that even though the proportion of the population in any one of these segments is remarkably stable, the individuals, so those percentages in those bars are remarkably stable. People are moving. They're moving from the moderate acute into the minor chronic. They're moving across in different ways, and you can see people shifting. And so we need to be able to have a system that can address and adapt the fact that people at one point in time, in 6 months or a year, may be experiencing different health challenges. So keeping that in mind. And that was very aggregate, but we need to really take this down to more specific groupings where we can actually plan care. Care pathways are very specific groupings. Care models might be a little less specific. So let's talk about how they might evolve if we think about some particular population groups and thinking about what their needs are. And one of the ways to sort of filter this is to think about prioritizing. And one of the, this is sort of my 5-step view on prioritizing, that you have a high burden population, there are gaps in care, you have evidence-based interventions and targets to fill those gaps, and then you have willing providers to implement these models, and their implementation supports available, such as funding, quality improvement, and some people asked us about earlier in the chat about what supports are available. Mike will talk about some, OH has some, We provide data as part of that. So let's get into that. We're going to talk mostly about the first two of these, specifically as it relates to diabetes today. But you could think about going through this type of an exercise with all of these. These were year one populations from the first cohort. They were, also popular in the subsequent cohorts of OHTs, but also new ones are being added, and some OHTs have chosen diabetes as one of the areas. And then when you think about each of those, where are the gaps in care? So we've shared out results like this previously, about a year and a half ago, I think now, for many of these mental health frail older adults, that each OHT is able to say, where are you relative to other OHTs in terms of the opportunities for improvement? And should you be compared against all OHTs? Well, no, we're going to do a whole peer grouping exercise in the year to come. But until then, just knowing relatively how you stand, I think, is still a useful understanding, and you have the exact levels of your performance. So we're going to walk through a little bit of an example here around high burden population, gaps in care, and then we'll start talking a little later about evidence-based interventions. This is the entire population of Ontario. This data actually comes from prior to the Ontario Health Team work from the Health System Performance Network. And this is the incremental individual patient-specific annual cost, incremental cost, so not the total average, but incremental costs associated with different conditions in Ontario. So the renal associated costs, the CHF associated costs, and on down the line, and you can see what those were. But at a population level, you have both individuals, and then it matters a lot how many individuals are in those. So we don't actually have a lot of people with renal conditions, and we have a lot of people with hypertension. And so even though hypertension at a per person is relatively low, at the provincial level, it's the one thing we spend the most on, actually. And you see that a lot of that money actually gets spent on people who are hospitalized. So hypertension is a risk factor for many of the other conditions. And so incrementally, those people incur a lot of costs. You also see other mental health and the prevalence of diabetes playing a role here as well. Here is, if we map those two things together, the individual patient cost across on the right side. So you see, we have some of the conditions where we actually have already developed system programs for, like renal in Ontario. We're talking about new pathways for CHF, for COPD, for stroke. You see those there, individually high. And then way up at the top, you see the ones that are really a population impact: hypertension, diabetes, and mental health. So we're going to dive in partly because of this, that we have a high burden population with diabetes. So let's move one step down. And to get to the question that many people asked early on, what about the other things people have? So one of the first things we should understand of people with diabetes is what other comorbidities do they have? And what are some of the other challenges that we might need to think about besides just diabetes management? And right after me, Lale is going to talk about diabetes management specifically, but I want to give, don't forget when you're talking about that we have these other issues. So here are three things. One, almost nobody with diabetes only has diabetes. 90% of people have more than one other condition, and multimorbidity has actually increased since this chart was created back in 2015, such that the level of multimorbidity, and the people who only have diabetes is a little bit of white space to the right there. So you can see that that's actually a relatively small proportion. And lots of people have 3, 4, or 5 or more conditions. And we're only counting the conditions that are actually on this list. So we don't have things that are commonly in here like hyperlipidemia and others that I know that Mike has on his list. So this is just letting you know that people have. And so, what are the person-centered approaches? And here's another one, because many people are also needing to manage cancer screening. So as you're in seeing people with diabetes for the diabetes management, keeping in mind that maybe pay attention to whether they are up to date on their cancer screening. So we see here, and this is one of the first places where we're starting to show some equity-oriented data, that the people who are in the least deprived neighborhoods at the bottom, so they have the highest socioeconomic status, they are relatively few in diabetes because there's a big gradient. This whole gradient you see here and the length of the lines is the number of people with diabetes. See fewer people in that higher socioeconomic status. And their screening rates, 56% or 10% better than the people in the areas of highest deprivation neighborhoods. So keep that in mind, 10% better. That's like 20% more people are screened when they are living in a neighborhood with high socioeconomic status. So this is something to bear in mind. This is true across, certainly amongst the women, but it's also somewhat true in the colorectal screening. And we actually have these data now. This is provincial data for every OHT. We may be adding them into your data packs when we do an update in a couple of weeks. So just to let you know that that is all the other things. And now here's something related to people with diabetes and non-diabetes as they relate to these care pathways. So there are care pathways for CHF, COPD, stroke, and lower limb. And you see here the proportion of the population with diabetes that are having hospitalizations, which will trigger those pathways or associated with those pathways in terms of the care management and the funding. And first off, you can see that they are a lot higher among the people with diabetes than among the people without diabetes over time. And there's a little bit of fluctuation here year to year, but they're pretty relatively stable, I think, over time. And so a large portion of the people that you'll be managing for CHF and COPD have diabetes. Keep that in mind as we go ahead. And then the diabetes management actually also impacts sometimes on their care in that regard. So let me turn it over to Lale now to talk through some of the very, very specifics of diabetes management. Lale, over to you.
Thank you, Walter. Hello, everyone. I'm Lala Rashidian. I'm a PhD student at the University of Toronto, and I'm currently conducting research on access to care for diabetes. So now we're going to focus on diabetes and see what OHTs can learn from the data that is provided to them using diabetes as an example. So we will be looking at 5 specific diabetes-related indicators, which are listed here on this slide. So the first 3 of these indicators, patients up to date with HbA1c screening, patients that are up to date with retinal examinations, and patients that have had statins dispensed, these are related to diabetes management at the population level. They're not outcomes per se. And the last 2 of these indicators, we have hospitalization for long-term diabetes-related complications and proportion of patients with HbA1c levels greater than 7, meaning that their HbA1c is not under control. These 2 are outcome indicators, and they show us how patients are doing overall. Next slide, please, Walter. So we will be looking at all of these indicators using an equity lens. And the marker of equity that we will be using is the Material Deprivation Index, which is based on Canadian census data from 2016. Basically, what this does is it looks at things like income, educational level, housing quality, and family structure. And it's closely related to poverty, it's related to access to care and patient health outcomes. And this data is split into quintiles. So in the Q1, which is the bright green, we have our least deprived neighborhoods, all the way to the Q5, which is the most deprived neighborhoods in the dark blue. So in this image, which is based on the most recent year of data, we can see all our OHTs stacked. And at the top, we can see that we have some OHTs that have up to nearly 40% of their population in most deprived areas, while at the bottom, this is less than 10%. Next slide, please. So now let's look at prevalence of diabetes across OHTs and see what we can learn when data is presented in this way, which is the format which is used in the HSBN reports. So here we have prevalence of diabetes across OHTs based on the most recent year of data. In the top panel, we can see there are lots of colored dots. Each colored dot represents an OHT, and these have been sorted. So on the left, we have more desirable values, which in this case is lower prevalence of diabetes. Moving on to the right, we have less desirable values. And the way that these have been colored is OHTs, which have a higher proportion of their attributable population living in least deprived areas, are light green, moving all the way to those who have high proportions in most deprived areas in the dark blue. And the dotted line in the top panel represents the average across Ontario. So with the prevalence of diabetes, meaning the proportion of our population over 18 who have diabetes, we see that the average across Ontario is 13%. This ranges from around 9% to 16%, which is an almost 2-fold difference across our OHTs, showing that this shows that we have high variability. And you can tell here with dark blue dots that they're clustered more towards the right, which means that there's a correlation with deprivation, a correlation of 0.5 to be exact. Moving on to the bottom panel, in this panel, we're not looking across OHTs, we're looking within OHTs themselves. So what we do is within each OHT, we look at the most deprived subgroup of the population and the least deprived subgroup of the population, and we compare the measure we're looking at, in this case prevalence, to see how they're doing. So if we have similar rates of prevalence in our most deprived and least deprived subgroups, the ratio of this would be 1, and it would fall on the dotted line, and we would have equity. But if the dot falls above that dotted line, then it means that we have higher prevalence in our more deprived subgroups. So in this case, you can see that all of our OHTs fall above the dotted line. This means that we have higher rates of diabetes prevalence in our more deprived areas within each OHT. Next slide, please. Now let's look at how these diabetes indicators have changed over the past 3 years, particularly since in 2020 we had COVID-19. So on this slide, we have our 3 population management diabetes indicators. So we have the HbA1c screening, we have the retinal screening, and the statins dispensed. So if we start off with HbA1c screening over here on the left, you can see that in 2020 compared to 2019, there was over 10% drop in the proportion of our patients that were up to date with HbA1c screening. In 2021, this has recovered somewhat, but it's not yet at the level that it was prior to the pandemic. Another thing that we notice is that across the different income quintiles, the different colored columns, they seem to be doing relatively the same. There isn't a gradient that we can observe just by looking at this data. Moving on to retinal screening in the middle of the screen. So again, we see in 2020, we have a drop compared to 2019, and this has continued to drop in 2021. When we look across quintiles, we see that Q1 through Q4, they seem to be around at the same level. There's a little drop in Q5, but again, this isn't a strong gradient. Moving on to the proportion of patients with diabetes that have had their statins dispensed on the right, we can see that over the course of these 3 years, this proportion has remained relatively stable. And again, we don't have much difference between our different material deprivation quintiles. Next slide, please. Here we're looking at our 2 diabetes outcome measures. So we had the proportion of patients with good control and poor control, and patients that have diabetes-related long-term hospitalizations related to long-term diabetes complications, such as amputations, blindness, etc. So if we start off with diabetes control on the left, we can see, first of all, the thing that comes to mind is that here we have that gradient. We see that the proportion of patients with good diabetes control is higher in Q1 in the low deprivation group across all 3 years. Conversely, we see that the patients with not good control are higher in our high deprivation groups across all years. And again, we notice that the proportion of patients with good control has dropped, and also those with not good control has dropped. So this might seem counterintuitive at first, but basically what it means is that the proportion of missing data has gone up. This aligns with what we saw in the previous slide, meaning that fewer people got their HbA1c tests done during COVID. Now let's look at the hospitalizations on the right. Just one thing to take note of, that the range here is between 0% and 3%, so it's not a huge range, but still, when we look at the data, we have a strong gradient, meaning across all 3 years, hospitalizations were happening at higher rates in our more deprived groups. But over the 3 years, the hospitalization rates does not appear to have been greatly impacted by the pandemic. Next slide, please. Now we'll look at each of our diabetes indicators separately. So here we have the proportion of patients that are up to date with HbA1c screening. This is diabetes patients over the age of 40 that have had at least 2 HbA1c tests within the past year. So the average for this across Ontario was 47%, but this ranged from 30% to 56%. So again, almost twofold difference across our different OHTs. There doesn't seem to be clustering of the dark blue, but we have a weak correlation with deprivation. They're not clustered to the right or to the left. And here, when we look at the bottom panel, we can see that most of our OHTs are on or very close to that dotted line, meaning they're close to that ratio of 1, meaning we have equity. The proportion of patients that are up to date with their screening is the same in our more deprived and less deprived subgroups. Next slide. Here we have patients with diabetes over the age of 40 that are up to date with their retinal examinations, meaning they've had at least 1 retinal examination within the past 2 years. So the average for this was 61%. This ranged from 55 to 71%. We have high variability across our OHTs. There is no clustering of the dark blue to the left, so we have weak correlation with deprivation. And when we look down in at the bottom panel, they seem to be nicely laid out along that dotted line, which is indicative of equity. We have the same rates of retinal examinations in our more deprived and less deprived groups. Next slide. This is the final process indicator. This is a proportion of patients with diabetes over the age of 65. So this is based on the Ontario Drug Benefit Program that have had statins dispensed within the past year. So the average for this was 72%. This ranges from 61 to 76% across our OHTs. We do have a couple of outliers here on the right, but if we take those into account, we have high variability across our OHTs and a very weak correlation with deprivation. Our dark blue OHTs are scattered throughout the image. And when we look down at the bottom panel, they're all on the line. This is indicative equity again. So patients in our more deprived and less deprived groups within our OHTs are getting their statins dispensed at the same rate. Next slide, please. Now we're going to look at our two outcome indicators. So this is patients with HbA1c levels greater than or equal to 7, meaning that these patients are not in good control of their diabetes. One thing to note is that with these outcome indicators, this slide and the next slide, the findings have been risk adjusted based on age and sex. This allows us to better compare our OHTs. So the average for this was 38%. The range, that means that 38% of our patients are not in good control. So this ranges from 31% to 57%, again, almost a twofold difference. We have high variability across our OHTs, and the dark blue dots are more towards the right, where we have fewer of them on the left of this image, which we have a weak to moderate correlation with deprivation, a correlation of 0.3. And when we look down at the bottom panel, most of our OHTs fall above that dotted line. What does that mean? That means that patients with poor control are more likely to be found within our more deprived neighborhoods within our OHT. Next slide, please. And on to our final indicator, hospitalization for long-term complications. This is a proportion of patients with diabetes over the age of 18 who have had at least one hospitalization for a long-term diabetes-related complication such as amputation, blindness, kidney failure, etc. within the past year. The average for this was around 2%, but this ranged from 1.3 to 6.2, more than fourfold difference. However, we do have an outlier here on the right, as you can see, but when we take that into account, we have high variability across our OHTs. And moving down to our bottom panel, you can see that they are definitely not sitting along the line, and almost all of our OHTs are above that 1% line, meaning that patients are getting hospitalized in more deprived neighborhoods at a much higher rate than they are in the least deprived neighborhoods. Next slide, please. So to summarize, what we see from the data is that overall diabetes management is moderate. 47% of our patients are up to date on their 2 HbA1c tests within the past year, 61% are up to date on their retinal screening, and 72% have received the recommended statin therapy. And what we saw, if you recall, we had a high degree of equity in these three population management, the screening indicators. But what we did see is that there were inequities in our health outcomes associated with diabetes, meaning that patients from more deprived neighborhoods had high hospitalization rates for diabetes-related complications, and they also had high proportions of HbA1c levels that were greater than 7, meaning that their diabetes is uncontrolled. And moving on to our key takeaways. So overall, in order to achieve diabetes management in our population, we will require new strategies to reach those individuals who are not up to date with their diabetes management. It's vital that patients access care, but we must make sure that the care that they are accessing is effective. And also, there's likely more to reducing diabetes complications than just diabetes management. Social determinants of health likely play a role in this, and diabetes management at the population level will require coordination across our different healthcare sectors. More research, my PhD thesis will look more carefully at the drivers of good and poor diabetes-related health and hospital outcomes. And over to Walter. Thank you.
Thanks so much, Lale, for all that very, very, very useful information and knowledge about the indicators itself. Yeah, those are, we're not discounting outliers. I see Camille, but and really, good to see these data points in. Just going to do a little bit of engagement and then come back to some questions and some of the polling that's happened along here, or sorry, some of the chat that's happened along here. So the first one is I'm going to ask about diabetes first, and whether your teams, having seen these data, your teams, you probably haven't shared them widely yet. We only sent them a few weeks ago. We just want to make sure you did have them. Whether you think there are opportunities to improve care for people with diabetes, and I'll ask it in the context of the next year. And you could say, answer multiple different options here. We understand that everybody is not going to be focused on diabetes. This is not a test or a focus, but also as you're even considering the other populations, as we mentioned, to keep diabetes in mind. And one of the stories I didn't tell, I'll just finish while the people who are putting in their votes still, I see it's still quite active, is the importance of diabetes management in the case that people have other acute events. And one of the first, everybody just came through the COVID, and we're all still managing and dealing, in fact, very much with the COVID pandemic. Early data right off the top, population level data, showed that the third worst condition you could have if you happen to get COVID in terms of your outcomes of being hospitalized, being put in an ICU, and then dying, was having out of control diabetes or unmeasured diabetes. They were both. It was UK work, and the worst you could be was to be an organ transplant, and the second thing to be under active cancer or recent cancer treatment, and the third worst thing was to be uncontrolled diabetes. So it plays a role at many, many things. And if you were to go back and look at what the most extreme adverse events out of the SARS pandemic were, it was also related to people with diabetes. So, it's always underlying and not something to be taken off the radar. So I'll share back this set of results with you, and then we're also going to talk about applying these principles to other. So most people are actually saying that the team does have an opportunity. And in fact, actually, I'm relatively surprised, 45, almost half of the people saying that, your team actually aims to improve care for people with diabetes and is highly likely to achieve that. That is very, very inspiring today. And I think we've hit on something that's actually much higher than I would have expected when we started planning this work out last year. Actually, we started planning this work. So I'm actually going to go on to the next one, which is, a little bit of an understanding of what other population groups you may be interested in working on. It's also parting to head our planning as we start looking out ahead of how we can support people. So if you can check multiple ones if you have different areas that you're interested in, that your OHT is going to be working on. Some of these are already there. So if you could submit that, and you may well, in fact, have other population groups, and I will suggest to you that you pop those in the chat. Things that you are primarily focused on that you don't see reported here. But for now, let's see where your areas of interest are going to be. And I can definitely see that people have multiple areas of interest. So keep them coming in. And this helps us, also get shared communities around these work and help to focus, the areas that we from HSPN from a data perspective, and I think RISE from a coaching and a leadership perspective, we'll think about the areas that people are focused on. So it is slowing down. I'm going to end it off here and share back the results so people can see that older adults is at the top of the list with 61% of all people. Kelly K is out there going, that's both inspiring and also going to create a lot of work. And Kelly had a very interesting chat point earlier with Mike responding. In that area of older adults, most of those people have 3 or more chronic conditions. And as you get older and older, it becomes more and more challenging to have pathways that really make sense and really needing to have a person-oriented approach. And I think Kelly would agree with me on that. And really focus in there on the integrated care aspects. But we also see a lot with serious mental health disorders, and then the less serious. I tried to split those out. Depression, anxiety, for those some people it is very serious, but we also see a good proportion of the population on CHF, COPD, and now I'm looking for people to enter into the chat the other areas that you are interested in. Maybe sort of
Walter, I just wanted to add something, just looking at this list, if people are really concentrating on serious mental health or depression, anxiety, the realization is that there are a lot of people in those populations with diabetes. And so even though that you may be serving particular people with particular disease groups, again, they have multiple disease groups, so you may be able to work on both diabetes and depression together as you move forward.
Thanks a lot, Rob. Excellent point, right? And we're trying to, build the appreciation. And Sarah Milne has been very active in the chat. Thanks, Sarah, really for your comments. You put a few things in. One is using EMRs to their maximum advantage, where you have that opportunity to get those triggers. And she had some points in around poverty screening in primary care and cancer screening flags in primary care to keep track of them. Some of the other areas, people working in the area of osteoporosis and hip fractures, yes, definitely. And those individuals are very frail and very interested in that work as well. I got a question, and I'll pop it up so people, and I want to come back a little bit to some of the comments that were out earlier in today's event. And it's this question of implementation. And you talked about, some people talked about, well, I have the knowledge and awareness, but I'm having challenges on the implementation. I'd like to see maybe a little bit of chat around this, opportunities to advance, based on your knowledge and also your challenges. So you had that, I think it was Christine Olson had the question first around this, but other people voiced it as well, is that you have the knowledge, and then there's the challenges and opportunities to advance those. So maybe we could pop a few of those in the chat, and I'll just kind of see, and I think it's going to be a nice little lead into some of the solutions that and approaches to solving and addressing some of these issues. So there's also a point earlier on the syncing together, building pathways. How many of the pathways are also going to include end of life and palliative within them? And I'd suggest that, if you're looking at managing care for CHF patients, that you need to be thinking about end of life and palliative care, because not everybody, but a subset of that population been living with those conditions for a long time are really nearing end of life, and how to ensure that they have opportunities to talk about their goals of care with family and with other providers, and that care models and pathways, and keep that in mind, what individuals' goals of care are, particularly as they advance towards the end of life. And a big challenge in healthcare so far, Lisa Rudenizer, I'm not sure if I said that quite right, is collaborating with social services, and greatly needed. So I think hopefully, and that's going to be part, and I really think I encourage you as OHTs to try and make that part of your tables and part of your planning, is to include home care, but also to include social care as much as possible, and think about, and I know there are many different agencies who receive funding for many different services, but how do you start to match make that? And we have, if you go back to our November webinar, or actually, so it was December, Alberta Health and Richard Levansuck talked a little bit about some of the ways that they are trying to organize the engagement and integration of their social services within and alongside healthcare. So I think that that's an important piece. And other comments, Helen Lung, around not adequately being able to address social determinants of health, not having the resources. And like, how do you do that screening? And if people do that screening, how do you then link people in? Christine Colsey, resources having hospital-centric Ontario Health team and corresponding funding rather than being community-based. And I think hopefully one of the things that will be able to emerge out of the some of the pathways work is the opportunity to take hospital money and move it into the community. So with the CHF bundles and hospital budgets being protected for funding, that there would be an opportunity that even if volumes can be reduced, that money can be reallocated to communities. And that's not an easy conversation to have, but I think it's a necessary conversation to have to enable that to begin to happen. Socialization programs, including nutrition and exercise, may be highly enjoyable and not viewed. So Helen Cooper's optimistic there about some of the opportunities to advance some of the care models in your OHTs. And I can say one of the most important things is building on relationships and continuing to build trusting relationships across the members of the OHT with a shared vision. That shared vision is so essential to be able to understand that people are all managing different aspects, but often of the same problem. There's the old allegory of walking around the elephant and only feeling certain things at a time. Well, by putting people in the room to talk about that elephant, we can start to share those stories. And I encourage you locally to be able to do that very effectively. I really, please, your opportunities, the things you're seeing to succeed and the barriers and challenges, please continue to put those into the chat, and we'll continue to watch those. I really want to make sure that we have a good amount of time to hear from our colleague, Mike Hindmarsh, who has an immense amount of experience and exposure in this area. Mike, maybe you could lead us through some of your ideas here.
Sure. Thanks, Walter. The theme, while we've been talking about diabetes throughout this, and I will also be talking about diabetes, the theme that I want you to keep in mind when I'm talking is about building systems of care that manage multiple chronic conditions and manage people with multiple comorbidities. The work that I've done over the last 20 or 30 years, it has moved towards that kind of system building, but often teams need to start with a particular disease to build the infrastructure that can manage multiple chronic condition needs, as well as preventive, primary and secondary preventive care needs. So we know, when we look at the model that Rob presented earlier, we have our larger system here, and the care models are what you're going to be building, the integrated care models. Part of those models will be care pathways, disease-specific possibly, and certainly disease-specific guidelines. But in the past, we typically started with guidelines and then tried to build the system out. And that doesn't work well because of the obvious comorbidities that patients have. So what we're really talking about is building down in, building a larger system with infrastructure that can manage multiple chronic conditions. Our current system came out of the First and Second World Wars, where we were reactive. The orientation was rescue the soldier, repair the soldier, return the soldier to battle. And that acute care system still does a great job of managing short-term illness, injuries, those sorts of things. But what we have to build now is this system of people that need long-term care, people that will have chronic conditions for the rest of their lives that will become progressive over time. And so, as I said before, we often, in the work that I've done across the US and in Canada, we started with diabetes because it's an odd thing to say, but it's kind of the perfect disease to do integration work because of the comorbidities and where it touches all points of the system. So let's go to the next slide. So keep that theme in mind. I'm talking about building a system of care for all chronic condition. But we're going to talk about diabetes as a starting point for that. You saw lots of diabetes data today, and so this is just more of that. I'm not going to spend too much time on this slide, but suffice to say that patients don't come nicely packaged just with diabetes. You saw earlier, 90% have other comorbidities and serious comorbidities, and many of these people with their comorbidities need intensive clinical care as well as self-management support. And I'm going to keep emphasizing the self-management support piece. Let's go to the next slide. So in the 5 steps that Rob presented earlier, our second step was about segmenting the population. And how do we go about doing that? There's lots of different ways to segment the diabetes population. You could do it by A1Cs. You could use multiple indicators like A1Cs, cholesterol, blood pressure, presence of end-stage conditions like kidney disease, neuropathy. You can look at age and number of high-risk chronic conditions across the population and segment them that way. You can also look at confidence in managing their health. So I'll just quickly show you how those would look in the risk pyramid that Rob also presented earlier in the session. So if we want to do it by A1C control, Here's one way of thinking of the population. The healthier patients at the bottom with pre-diabetes or well-controlled diabetes, the people with rising risk who have poor control between 7.6 and 9% for the hemoglobin A1Cs, perhaps high-risk folks that are uncontrolled with multiple comorbidities, and the extremely complex with end-stage complications, lower extremity amputations, end-stage renal disease, blindness, so on and so forth. And keep in mind, as you go up that pyramid, you also have equity issues, you have marginalization issues coming along with that medical complexity. So we also have to keep that equity focus on the pyramid. Let's look at another example. Here, people, if you look, I know one particular practice in Victoria, BC, all the providers on Victoria Island tracked the people that had all their A1Cs, blood pressure, and cholesterols in control. So they segmented the population that way. All indicators in good control were patients that were relatively healthy. Rising risk, one indicator was out of control. High risk, all three were out of control, and complicated patients had poor ABCs for 5 or more years. And the next example. Just go back one slide. Yeah. So again, here we can look at the social determinants and as well as control issues. So if you take people's things like A1C, their blood sugars, other clinical indicators, and start looking at their overall health, people that have stable income and housing, could be the healthier patients at the bottom, possibly people with changing life situations or have become marginalized or have control issues. The higher risk people are folks with poor health literacy, low income, low education, poor access to the system, as well as poor clinical control. And then clearly the complex could be the most deprived people coupled with uncontrolled diabetes. Now there's going to be mix and matches within those various strata. But it's just to give you a sense of how you can start thinking of the population and how do you start stratifying them so that you can target interventions appropriately, because obviously an intervention for people that have good overall health, stable income and housing is not going to look the same as an intervention for people who are most deprived and coupled with uncontrolled diabetes. Let's go to the last one that we can compare. This is a relatively new science, but when we think about self-management support, and the goal of self-management support is to increase patient self-efficacy or patient confidence. Work done by Wasson et al. Out in Dartmouth, they actually took practices and had the providers measure the patient's confidence in managing their health. And I won't go into the details of that, but it's a fairly simple question that you can ask patients. And when he coupled that with their control of their chronic condition, in this case it was diabetes, he produced this grid. So people that were highly confident in managing their care and had good clinical control basically just needed good usual primary care. People with poor clinical control but high confidence needed some tweaking. So they needed to be doing action planning, goal setting to get their control under better control. People with low self-confidence but good clinical control also needed action planning just to boost their confidence and make sure they could continue to take care of their chronic condition. And then obviously in the red section there, people with low self-confidence and poor clinical control typically needed interdisciplinary team care. Multiple providers working with them not only to improve clinical care, but to boost that confidence level in managing their care. So that's another unique way of thinking about stratifying. So in these last few slides, what I want to do is emphasize that we have to build a generic system of care that manages all chronic conditions. And so what I'm going to do is go through the different community partners and go from the generic. So in this case, you see primary care and you see the generic disease registries are needed. If we're looking at diabetes, it's all patients coded with 250.XX in the EMR. They may want to also add what are the comorbidities that these patients have. Generic, all people without a recent visit. In the case of diabetes, you'd be bringing patients in with high blood sugars. So you're using electronics to do recall systems for patients out of control. The visits need to be different. Our chronic care visits need to be longer. They need to visit medications on a regular basis. They need to, in the case of diabetes, foot exams need to happen, renal screening, A1Cs, LDLs, and self-management support. And there's some data in the PAM scores that would help you with confidence. But those planned visits would have a similar structure across chronic conditions. Same thing again, prevention. Prevention should be a part of every chronic condition visit. In this case, you want to make sure patients with diabetes have pneumococcal vaccines, COVID vaccines. Someone's done a social determinant health assessment so that they can hopefully prevent some of the impact on outcomes that SDHs have. Again, self-management and cancer screenings. All of these things are what need to happen at that visit. There are provincial supports, again, for doing chronic disease systems. There's an Ontario self-management program that trains staff in brief action planning and provides chronic disease self-management programs for patients to come and learn how to manage their chronic conditions. And then we have national programs like the ECHO programs. Let's go to the next slide. So again, across all of this, we're talking about integration. So while primary care is doing all of that, they need to be integrated with the hospital. And from the hospital standpoint, they would be providing coordinated care during inpatient stays. So some unique sort of internal integration is having joint multidisciplinary assessments at the bedside. So rather than having an endo come in one day, a nephrologist come in the next day, a chronic condition specialist the next day, everyone's at the end of the bed talking to each other about how to manage that patient. When we talk about integration outside of the hospital, we need to have discharge summaries that are attached directly to the primary care practice or wherever the patient's being discharged to, but typically primary care, and that the hospital schedules a visit inside the primary care schedule to make sure that that patient is seen and the discharge summary is located in that scheduled visit. For acute exacerbations, again, the hospital needs to do some of the work that primary care would be doing to make sure that there's partnership there. So if people are coming in with high or low blood sugar events, make sure they're referred to the Diabetes Education Center. All of this is coordinated with the PCP. And again, more integration work, prevention. So if I come into the EMR, or excuse me, if I come into the ER with a high blood sugar, someone checks to see if I've had my diabetes vaccinations, checks to see if I've had an annual foot, renal, or eye screening, checks my cancer screenings. And all of that information, whatever the hospital does for me at that point, is sent back to the PCP EMR. Let's go to the next community partner. Specialists. This has been a tough nut to crack for everyone for the past few decades, but we have to engage specialists in population health management. Any specialist should be looking at their panel of patients that they see from a registry perspective. So make sure that the endocrinologist has not only registries for thyroid issues and other endocrinology problems, but they have a diabetes registry, and that their referral agreements with primary care are very structured. That is, they get exactly the data they need from primary care, and they send back the data and recommendations that primary care needs through not only electronic mechanisms, but referral agreements that make sure that they both get what they need so that the patient can be better managed. Another thing I've seen is joint visits by special State. It was incredibly successful, where an endocrinologist would visit with the primary care practice for specific patients that the practice identified. The PC team would be trained in evidence-based care, and the nurses were trained in self-management support for patients. So there's lots of integration work we can do with specialty, and I think that's got to be a big part of this focus also. And then let's just go to hopefully it's the last slide. I'm going to speed this up a bit. No matter where the patient touches the system, they need to receive some level of education and self-management support. And we have no shortage of provincial supports for people to be trained in very simple self-management support techniques that are patient-driven. So it's one thing to teach patients about how to take care of their diabetes and then tell them they need to eat and exercise more. It's another thing to ask the patient, what is it you want to work on in terms of managing your health, and then helping them set an action plan that they can achieve and build that confidence. Because once they're confident, there's a causal link between patient self-confidence and clinical outcomes. Next slide. Home care. I think there's a great examples already in the province of integrated patient care teams or integrated primary care teams, as sometimes they're called, where home care is being used as care coordinators to work with primary care to manage patients that are rising risk and at risk of complexity. So again, more integration across systems. Next slide. I think this is the end of my work.
Yes, the one. Yeah. Wow. And people are definitely appreciative bringing it to life, Mike, says Jocelyn Denome. And so I want to put out to the audience here participating today this sense of your ability to maybe put some of these pieces in place. And so how confident might you be in using these approaches to build a care model for people with diabetes? Or in fact, I think, Mike, you would probably agree with me to say that the general approach of including primary care, of thinking about how to identify people, what the points are you're trying to touch on, how to identify people with both medical and social risk, could be applied to other populations or other groups. And so a confidence in building a care model for people with other diabetes. And I think someone had popped in the note that maybe this will be a recording that gets watched over and over again for those key lessons. And I think, Mike, people might want to see the data, but this practice-based approach, we might just pull it out and with your permission, make it available as a special tutorial on this. I'll say, while people are just finishing putting in their some of their comments of their confidence in being able to do this based on some of these lessons. Catherine asked, you mentioned something about a primary care diabetes registry, and what did you mean by that? This is Catherine Whiteside, former Dean of Medicine for U of T, and now I think the Executive Director for Diabetes Action Canada.
Oh, terrific. So Catherine, it's very simple. Just go into the primary care provider can go into their EMR. Most EMRs have this functionality, pull out all the patients with diabetes, and then they can start doing reports on at A1C levels, but more importantly, and probably the biggest impact, is doing exception reports of patients that are outside of guideline care. And bringing those patients in for care, patients that haven't been in the last year, patients that don't have a recent A1C, those sorts of things. So that's at the primary care level, that's the biggest impact they can have using disease registries.
Yeah, and I think that making those more available and more widely used, I think I know I've seen some examples with Ontario MD and some other uses, and I think Sarah Milne referred to some that they've been building up. I know there's a community north of Superior, I think, that actually even does this in a rural setting. So as long as you have that EMR and some capability with digital management of that EMR, that this is definitely feasible and possible. Mike, I think people are inspired by you. People feeling that they do have some confidence in their ability to build care models and implement those care models. They had to put themselves in one spot. And I would say that we have over 80% are higher, somewhat confident or higher. And that's at least sort of 70%, I think, in the above somewhat confident. So very inspiring, Mike, today.
And as I said, confidence is linked to success. So I think you're all going to be successful.
That's awesome. Awesome to see. So I think, Mike had said, wanted to leave this a little bit open on the question. So really, our discussion question is what questions do you have for Mike? So this is like ask Mike a question. And so let's see what kinds of questions people are coming up with. I think you've put that note in, and certainly more kudos to you thinking about devices, technology, and freestyle. I'm not sure what Libra means, but I think technology and devices. Have you seen roles and important value in using devices, technology in diabetes self-management?
Yeah, that's Mike, you're absolutely right. If patients have access to those types of devices, then it does engage them more in their care. They understand what the labs are that they're getting. They're understanding what blood sugar means, all of that. And so that's certainly one way to get people engaged. There's often health literacy issues with those types of devices. But again, that gives you an opportunity to help address what patients understand and don't understand about their condition.
Yeah. Great, thanks. And I don't see any other pieces coming into the chat right now. I'm just going to launch one last poll, and that is the usefulness of today's information. We often have this as a back poll that we often don't get to. But how useful is today's session to inform your approaches to population health management?
One suggestion, Walter, if I can, as people are responding here, just remind everybody that Mike is available. He is an OHT coach. We have other coaches that are just as capable in terms of thinking as Mike is. And I would really encourage you to bring Mike and the coaches right into your clinical working groups to work through the issues, to make sure that you're using their tremendous experience around population health management, care pathways, and all the types of things and the care models, the types of components that Mike was talking about today.
Absolutely. We can bring and sometimes share some data with people out in the Ontario Health teams, but the coaching and on the ground support really is the coaches and Mike and the others, and some of them were actually online today. I know Lori, I think I saw her, and didn't notice it, didn't have a chance to see if Christina was there too. But a lot of people getting a lot of usefulness out of today's. Appreciate that. It is, what we try to do here, and so I'm glad to see that. A few last little closing points. I do see some points in the chat. And knowing that access to primary care. So we are going to do more work in primary care, and other webinar coming up, not too distant in the future. Next month, we're here the fourth Tuesday of every month from 12 to 1:30 with hundreds of people across Ontario interested in supporting Ontario Health teams and engaged in this. In March, we have another collaboration coming up with IFIC Canada. This will be our third in a row almost, and it's around digital health for integrated care. So really, really happy to be working with other colleagues in advancing this on March 28th, advancing integrated digital health innovation. I was going to play a little clip here with Dr. Carolyn Steele-Gray and Axel Kane, who is the lead editor for the Journal of Integrated Care. And a lot of what we're going to be talking about are aspects out of a special issue. But if you want to get a preview on this, you can look up on YouTube Axel Kane or Carolyn Steele-Gray, or you can find it on the link that will be available after the event. I would like to especially thank our speakers today. We are very, very fortunate that we had Dr. Rob Reed, Dr. Laleh Rashidian, and Mike Hindmarsh really sharing with us their insights and all of the different aspects of their expertise. And I wish you all a pleasant afternoon, and I look forward to seeing you again in a month with some new excellent guests talking about digital health innovations in integrated care. We'll see you again soon.